Good afternoon. Welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician and Chief Medical Officer of Good Samaritan Physician Network. With me, as always, Adam Thacker, who's our Chief Operating Officer here at Good Samaritan Hospital. We'll be giving you our usual COVID update, talking a bit about numbers, some of the changes that have happened over the course of the past few weeks or so, and also summarizing the litany of different drugs and treatments and things that have evolved over the course of the last few months. But starting out with numbers, about 10,000 cases since we started here locally, but really the hot thing, of course, is what the positivity rate is, and truly spectacular. We have been doing this for almost a couple years now, and checking our data sources and looking at maps, and I don't think we've really seen anything quite like what we have experienced over the course of the past few weeks, which is a positivity rate in our unique individuals of 60% and of our all-comers of around 30%. And if we look at our state map, which we do very routinely, everything is red. There's nothing that's not red in the state of Indiana. So all of this sounds doom and gloom and murder hornets and the apocalypse is coming with the snow and things are bad. But things are not as bad as they seem. Can you tell us a little bit about what numbers we're seeing as far as the end result of this, which is really what matters, as far as inpatient hospitalizations and what we're seeing on that side?
Right. Well, who could have imagined that we would see positivity rates in the 60%? And before we started seeing that publicly reported, we talked, and I said, our lab's telling me we're seeing 57% at that time of the test coming back positive. And then we start to see inpatient census going up, which is inevitable. So, kind of dispel an early myth of Omicron is not that severe. We don't need to worry about it. Well, nonetheless, that there may be some accuracy to, in a global picture, Omicron is less severe than some of the prior variants. What we have seen is just the high transmissibility still leads to individuals that are getting very sick and needing hospitalization. So over the past few weeks, we've seen hospitalizations climb in the 40s. Last week, we've been consistently in the 30s. And when we say that number, if you're not in the hospital, it probably doesn't put it into perspective. But it's been 30 to 40% of our entire inpatient census has been individuals with COVID. Now, some are very sick, some are recovering, some are somewhere in the middle. They need a little bit of inpatient care, but go home fairly quickly. A lot of those individuals are saying 5 or 6 days, which also doesn't sound that long unless you're in healthcare and recognize that our usual length of stay for a patient coming into the hospital is in the 2 to 3 day range. So we're talking double or more length of stay that somebody's in the hospital recovering from COVID. Tremendous pressure that it puts on the organization because we are in the middle of healthcare shortages with staffing, supplies. That's a national issue. Certainly, we're seeing the impact from the emergency department, EMS, even getting patients to the hospital or from our hospital to other levels of care, and so forth. So just a lot of pressure overall on the healthcare system, which many have heard before. I mean, so much of this virus throughout the pandemic has been not so much, hey, everybody's going to die from the vaccine or from the virus, but everybody is not going to, but some may need hospitalization, and it puts a lot of pressure on the healthcare system as a whole.
Well, and the other thing to keep in mind that we always go back to is what is that population? What do they look like? What are their comorbidities? And that's something that has pretty much been consistent throughout the course of the pandemic, is looking at our highest risk population. And it's those individuals who are in general sicker, who have comorbidities, and those individuals who are not vaccinated, unfortunately. So when we look at that population, even though the Omicron variant is less severe and less problem as far as hospitalizations and deaths, the biggest issue really is it's still affecting some of those sicker populations in our patients. The other thing that we definitely see and have been seeing in the ambulatory population is the protracted recovery for some of those sicker patients. So one of the things that has been challenging as we have kind of ebbed and flowed from the beginning of this pandemic is what to do when you get symptoms. Early on, there was nothing to do. We had no tests. We had no treatment. We had nothing to do. And so it was all about social distancing and isolation and trying to keep that initial spread down. And then when we were dealing with those early variants that were more lethal and had more morbidity and mortality, it was about getting those patients early tested and identified. And so one of the challenges that we've encountered over the course of the past several months is that there has been a decrease in testing available and then a change in what treatments have been available. So testing has changed a lot. We had oodles and oodles and oodles of tests available 3 to 6 months ago. And then things started to change. And now where testing is available and how you can get testing, including home testing, has changed.
Yeah, it has. And just complete honesty, it can be difficult for the public to understand because we've been up here and said every message from go get tested immediately to don't get tested based off of the current situation. And we have to recognize that there is an ebb and flow to that situation. Where we're at now is we do have very good testing capability in Knox County and for the communities that are coming to Knox County. I mean, we talk to peers across the state and other parts of the country that we know professionally, and having same-day availability at our convenient care to test individuals is an outlier compared to what most are seeing and having to wait days. So that's a good thing, but there's also appropriateness of that, whereas if you're an otherwise healthy individual, asymptomatic, minor illness, stay at home. You do not need to seek, certainly not the emergency department, that's not appropriate, or the convenient care for what we would call curiosity testing, and in some cases fearful testing. Do I have it, do I not? You still have to manage your symptoms and go at it from that angle. Now, the higher risk individuals that may be appropriate for treatment, chronic lung issues, heart issues, immunocompromised, diabetes, obesity, all of those things that we've talked about for coming up on 2 years now as high risk, start to have symptoms and feel poorly, they should get tested because we do have treatment options that are available. They're much more limited than what they were a few months ago, but certainly treatment options continue to emerge, and we do continue to see those treatment options being utilized. But having same-day access scheduled through online through our convenient care is a great benefit. We're testing anywhere from 120 to 160 individuals a day, and as we mentioned, seeing a very high positivity rate, so able to turn that out. And then we talk about home test. Home test ran through a local pharmacy yesterday, just curiosity, would the shelf be bare or would there be tests there? And there were tests on the shelves. Earlier in January, the federal government rolled out that your insurance covers home tests up to 8 per month. So reducing another one of those potential cost prohibitive measures and really increasing access. So certainly folks that want to test for curiosity, minor symptoms, asymptomatic but think they were exposed, home tests are a great avenue for that, or no test, because we're really waiting to see if they do become ill, then seeking care. Certainly anybody who is trouble breathing, shortness of breath upon walking, fever that is spiking and continuing to climb, then we're here as the healthcare provider. Absolutely, we'll see people and take care of them. But we also, from a resource standpoint, we want to make sure that the people in the community seeking care here can be seen, that are sick, that are getting sicker, and make sure that we provide them care as early as possible, because since very early on, the earlier we identify somebody who's becoming progressively ill and can provide them treatment, the better outcome they're going to have.
Yeah, and so really focusing on that lower risk population that you're referring to, the curiosity testing, or really the lifetime planning, what am I going to do with myself, my family, my kids over the course of the next few days, that type of testing with the home test is very accurate. The home tests that are available are the same tests that we use at our convenient care. The Binax now for all of the first entire half of the pandemic. And it's a very accurate test. One of the key things to keep in mind, though, is that testing is most accurate after you have developed symptoms. And using it for asymptomatic testing does not work nearly as well. So we still really don't recommend within our system or for home testing to do asymptomatic testing, because the yield is very low and the information that you gain from that potentially would be misleading. So for a lot of the population that's otherwise healthy, we encourage people to pay attention to your symptoms. Certainly if you're developing symptoms or showing early symptoms, to stay home from work, to stay home from school, do everything that we would have done pre-COVID, which is be smart about what your symptoms are and protect those around you. And then once you're a day or two established into that illness, get your testing performed to determine what you need to do as far as your isolation precautions. And that has changed a lot too. And you know, what we describe to you here every time that we have our program is the evolution of what has happened with that versus you're going to be locked away for 2 months and nobody can do anything but slide pancakes under your door versus now breaking out to 5 days of isolation once you've been symptom free for 48 hours. So that's one of the things I think that has also been kind of confusing to the population. Now, we won't necessarily get into what each and every workplace and each and every school has recommended, but the idea is the illness that we are seeing now is generally more short-lived and less severe, and therefore the thought process is it requires less isolation.
Yeah, and when we saw that change, it was it was a challenging time to see the change because numbers were increasing when we saw isolation time shorten. But with the new variant, seeing that most of the transmission was early onset, 2 to 3 days, so we've shortened from 10 days to 5 days. Now, in the healthcare setting, we've stuck with that 10 days, except in exceptional situations where staffing would prohibit, providing the patient care that we need to be able to provide. But overall, that has worked. And nationally and even here in this community, I think we're somewhere between trying to strike this balance of lock everything down, everybody stay home, to we don't talk about COVID. It's those two spectrums, and we've got to get somewhere in the middle, and everybody's on a different plane for that. But I do think that as we continue to move forward, now that we're seeing we've hit that peak and things are sliding down, that we're feeling like we're in a good place with what the trend is showing.
And one of the other big things that has changed is what the available treatments are. So if we look back, one of the amazing blessings that came along was the monoclonal antibodies. Thankfully, we were very early in adopting those and treated thousands of people very successfully and prevented a lot of deaths and hospitalizations with that. And then unfortunately, when the new variant came along, those previous monoclonal antibody therapies were not as effective. However, we're fortunate that, of course, our scientists are doing what scientists do in the background and working through what is working and what's not working, and so other treatments came along. And thankfully, those had been in the pipeline and in the works for a while. And so we do have a monoclonal therapy that we're using now. It's just in shorter supply, the sotrovimab. But then there have been a number of other, like true antiviral agents that have now moved into the ambulatory world. Some are oral, some are injectable. So we have several other options that we can play through besides just the monoclonal antibodies.
We do, and I think it's important to know we talk so much about vaccination, and that's that preventative step that has shown time and time again through the data that it absolutely is first line. That's what we want to do. And there were a lot of questions. Why are we so focused on vaccination and then treatment over here has kind of been left aside? The reason is if you can prevent something, you don't have to treat it. But as we have continued to see the COVID pandemic drag on and unfortunately unvaccinated be impacted the way they have, treatments have really continued to be developed, monoclonal antibody, oral treatments. And when we look at that, we're looking for that high-risk population, keep them out of the hospital. So when we talk about treatment, it's not preventing illness entirely. There's still going to be symptoms. These are high-risk individuals that either through sotrovimab, a monoclonal antibody infusion, through oral agents, can get identified through seeing a provider. So won't be able to do a home test, won't be able to call in and ask your family physician to prescribe these medications for you. Will have to be evaluated to make sure that that is appropriate because, as you mentioned, the supply is very limited. To put that in perspective, last week we were seeing anywhere from 100 to 130, I think, positive cases identified every day in Knox County and 60-some% positivity rate, and we received 18 doses of monoclonal antibody. So it's very limited, and probably important when we talk about treatment to do a little bit of a public service announcement. There are some areas that are still promoting bamlanivimab combo and Region Cove, which were the two monoclonal antibodies that we used in the thousands of doses and were very successful. FDA has actually changed the approval, and those are no longer approved because their effectiveness against Omicron significantly diminished to no effectiveness from where they were very effective against Delta. And we know we're 99%, maybe 100% at this point of Omicron. So if you do see outside of Good Samaritan, certainly, if you see that there is monoclonal antibody available, make sure that as a patient you're educated that sotrovimab, or just ask the provider, is this the one that's approved and effective against Omicron, because there is only one.
Yep. And then that population, what we've had to look at to be more judicious about what population is the highest risk is our 75 and older population is still a very high-risk population. And then when we look in that 74 and under population out of 50, it's the population that is unvaccinated and then has those risk factors that we continue to bring up. One of the other populations that really sort of got ignored early in the pandemic, which then later seemed to be having more difficulty, was our pregnant population. Those individuals early, mid, and late pregnancy have proven to be higher risk because they are somewhat relatively immunosuppressed. They have more compression of their lungs, and so they were developing more severe illness. One of the things that started happening more towards the fall of this last year was really focusing in on the importance of vaccinating that population, but now also treating that population.
Right, and it's a difficult discussion sometimes with pregnant mothers on accepting of treatment.
Absolutely.
Because at an all-time high is what's going into my body, what's affecting my growing baby, and the decisions that are being made with that. But then there's this risk of, if I get COVID, but what if I don't? And so Paxlovid is one of the oral treatments that is approved in pregnancy, very effective, safe and effective in pregnancy. And so just recently our pharmacy put together an algorithm. We've sent that to our obstetricians to identify if they have pregnant mothers that become COVID positive, that oral treatment would be a great option. Because as you mentioned, that is a population, as we look at groups of populations, that's at very high risk. And unfortunately, we've also seen that the vaccination rates for that population has tended to be lower than what we see on across other populations of adults.
Yeah. And speaking of the vaccinations, I get a question not infrequently now, which is, hey, I understand there's a new vaccine called Spikevax out, and obviously the appeal to that sounds fantastic. I want to go get Spikevax, can I get Spikevax? And so one of the things that we should cover is the fact that these drugs have drug names until somebody cleverly names them and they get authorized, full authorization. So
Right.
Can you talk us through a little bit about why we hear so much about the Pfizer vaccine, the Moderna vaccine, and then it comes to market branded, and that sort of changes everybody's perspective on what it is.
So as vaccines or drugs are going through the process of clinical trials and now in today's world of an emergency use authorization, they stick to their drug name, or in this case with the vaccines, a lot of times we've used their manufacturer name. Right. So Pfizer, Moderna are drug manufacturers. They make all kinds of different drugs and vaccines across the globe. Then Pfizer, once approved, became Comirnaty. So that is the brand name of the Pfizer vaccine. They are the same vaccine. Yep. Moderna came up with what we feel like is the coolest vaccine name. Somebody needs an award for coming up with that in their marketing department, of Spikevax. So Moderna and Spikevax are actually the same vaccine. So when you see news of new vaccine, Spikevax, it's newly fully FDA approved vaccine that is the Moderna vaccine, now called Spikevax. So the naming can be confusing, but we see that with Tylenol. Yep. So Tylenol is acetaminophen to you and I. So we see brand names and generic names, or brand name and drug name, that are somewhat used interchangeably. So Pfizer, Comirnaty, same vaccine. Moderna, Spikevax, same vaccine.
And interchangeability with those as well.
Yes.
Frequently, people will ask if I should stick with the same horse that I started riding or I should change. Statistics and data looked a little bit better on the Moderna spike vax as we kind of got later in our variants. But really, just making sure that you are up to date on your vaccines. Make sure that you are fully vaccinated, then you are boosted. Now, the question that is out there on everybody's mind, of course, is what does the future hold? And will we be getting vaccinated every 6 months, every 3 days? What is to come? And I think that we can all agree on the fact that there will be more vaccines in the future.
Right.
The frequency of those vaccines is going to vary tremendously on a number of factors, not the least of which is the prevalence in the community and in the society and in the nation and the world of the virus and what happens to it over the course of the next 6 to 12 months. And then also what happens with variants and how effective the vaccines are. And thankfully, this is all being worked out, and it's being done by people in places where this has already happened. So one of the amazing things that happened very early on in the pandemic is thankfully we all talk to each other. So across the ocean here, or across the sea there, across the country here and there, we were all communicating as to what was happening with variants, and that research being done in those places that has already been through what we're experiencing now 3 months ago is tremendously valuable data, and we get to learn from that. So I think you and I can agree that there will be seasonality to this. I don't think there's any question of that. I think we can also agree that at some point in time there will be flu and COVID vaccine thrown together, just as when we went through H1N1 and the expansion of the flu vaccine 2008-ish, whenever that was going on. That's going to happen ultimately with this. There will be vaccines available that have any and all, or pick and choose however you would like, just like we have now. But the idea is that that's going to become what the norm is, and as we deal with that globally, that will be focused on what's most effective.
Yeah, and I really think it's that transition, we say pandemic almost daily in our vocabulary now, to endemic. So pandemic is this global outbreak of a virus that is still causing a lot of disruption in daily lives, a lot of hospitalizations, illness, etc., to endemic, where the virus is still, for the rest of our lives, going to be present. One thing that's interesting when you look at endemic, though, coronavirus is already endemic. It's the common cold.
Yep.
So we just don't put the two together because you don't think of common cold and COVID in the same category, but they're both kind of families of that coronavirus. So as we're moving towards that, yes, we'll see seasonality. We anticipate that the vaccine world is forever changed with mRNA technology and improvement in vaccines. We've seen efficiency and effectiveness from vaccines that we have never seen before. So silver lining in the medical world is this pushed forward probably 2 to 3 decades research and focus that we might not have seen in our lifetimes otherwise. Certainly could have done without all of the negative side of the pandemic, but we are moving in that direction, and that's the positive piece of where we're at. Is we're at this point of where everybody's getting more comfortable with, okay, how do we live with this?
Yeah, and it's interesting to reflect, going back into like my early life, there was chickenpox season. And prior to chickenpox vaccine, everybody got chickenpox. And there was no question that at some point in time, your family would get chickenpox, everybody would get chickenpox, and then this would pass, and then there was nothing to do about it at the time. As time evolved and vaccines became available for that, it is extremely rare that anybody gets chickenpox now. And so the seasonality of what used to be chickenpox season, there is none. But influenza seasonality, gastroenteritis seasonality, interestingly, RSV seasonality has changed dramatically, and rotavirus seasonality has changed dramatically. So again, this will be something that will continue to evolve and will become commonplace, and that's what's down the road from us. Kind of looking over the course of the next several months or so, I think we've got several things working for us. This was a very hard-hitting, very short, very sharp spike and curve. We will be coming down off of that, as you've described, over the course of the last week or so, and we will be entering spring. And it is magical, and flowers will bloom, and unicorns will run across rainbows, and things will be fantastic. But the main thing is we go outside and we are less isolated, and we get more fresh air, and all of these things that reduce our normal viral spread anyway are just around the corner. So there is a bright side to this. We don't get to paint with the bright and happy brush very often, but things have been bad. Things are better, and they will continue to get better.
Right.
Any other big things before we move to the phones?
I think we just mentioned we are, on the front end of expecting some pretty significant weather. And it's important, I mentioned it very early on, but it's important to realize that we have significant shortages of staff. We have folks that are coming, making it here every day, taking care of this community. But there is not, years past, if we had a big storm moving in, we tried to get people to work, but if a percentage of our staff didn't make it, it wasn't a big deal. This year, it is a big deal, so we need everybody to be safe in the weather that's coming about. Use caution in driving on the ice and getting out and those types of things. Our team will be here to take care of whoever gets hurt. If you run into a tree with sledding, or if you have a heart attack, whatever the case may be. But it is something that we're putting a lot of effort to make sure that we get folks here, because we don't have the staff, and no hospital does today, but we don't have the staff that 2 years ago, pre-pandemic, when a storm hit, we didn't worry as much about, will we have people here to provide the optimum care that we need to.
That was a public service sledding announcement.
Yes. Watch out for trees.
Tiffany.
Okay, really the only question we have, I think you addressed it at the beginning, but just talking about the positivity rate, someone wants to know if the virus is still being heavily transmitted here in our community.
Absolutely. So the interesting thing about this variant is highly, highly contagious, much more contagious than any other variant that we've had. We talk about, though, that it is less lethal, less morbidity, less mortality, all those types of things, which is great. I was at a FAA conference this past week, and they had some population health speaking on there, and they were all quite certain that every human being in North America, every human being on the planet, unless they are living on an island with no outside source of contact with anybody, will have contracted COVID-19 by June 1st. Solid statement, no question that that's going to be the case. So part of that is just simply the fact that gets us to herd immunity very quickly. And that conversation about why herd immunity is so good is a little bit challenging, because we don't know how long that will last. But the fact that this has hit quickly, we are on, we are off, it has been nearly ubiquitous in our population, means that everybody has had it, and they will confer some type of immunity during that. There's an interesting variant. Some of my colleagues at Northwestern discovered the stealth variant of Omicron, which, again, beautiful job naming, Northwestern folks, good job finding it. But the interesting thing about that is it's less detectable, which, fantastic. That's what we really needed, is something that was just more challenging to detect. But yes, it is highly contagious, no different than the common cold is contagious and influenza is contagious, but this one happens to be in the spotlight, and that's why this is a bigger issue.
So as we go full circle, we'll be back talking about we can't test and just manage symptoms.
Right, yeah.
I mean, it's like waiting for parachute pants to come back into stock.
Oh, God, I love parachute pants. So many pockets. The kicker here is just that it's not as lethal. That's the thing that is the bigger deal. I have friends that live on both sides of the political world, and we will sometimes have a cocktail here and there and discuss the intricacies of playing the game this way and playing the game that way. The problem is that when we were dealing with the more lethal variants, we couldn't have had happen what is happening right now. It would have been an absolute disaster. Right. So going back and saying, well, we should have just all gotten herd immunity back when this started, this was a far more lethal virus when we started this out. And just as Adam and I have said for almost 2 years now, the expectation of almost all viral illnesses is that we will have variants, and they will generally degrade over time and become less lethal. And that is pretty much exactly what we have seen happen. What we hope is that there is no spike of a more virulent, more lethal variant. But again, thankfully, the scientists are in the background doing the things that we don't like to do. All right. Well, don't overwhelm the grocery stores. There's plenty of milk and eggs and cheese to go around. And thank you to Adam for the sledding public service announcement. So be careful, and we'll see you later.